We need insurance,
Mm-hmm.
but insurance is meant to cover things that are unlikely to happen.
Mm-hmm.
When in America, everyone needs primary care. Think of it like groceries. Could you imagine grocery insurance? Going to the grocery store and the checker telling you, well, I'm sorry, your plan doesn't cover T-bones. You get hot dogs,
Well,
well,
we
I
may
want a
be heading
T-bone.
that way.
Well, it's $3,000 for the T-bone, but the hot dog is 50 cents, They make these ridiculous pricing games to steer our behaviors that aren't even related to what it actually costs to produce the different services. I'm just trying to make sure Miramont shows on my
Got it.
left breast. So I've got my...
You can make sure everybody sees where you're from
Mhm.
and the biote.
Yeah, they'll have to pay extra. If they sponsor us, we'll make sure that gets in there.
Oh, okay.
Yeah, so I got to send Dee Dee some money.
I'm very thankful for them.
Yeah.
They keep me normal.
Oh, good. We can give them a little testimonial, I guess.
Some little-
Biote.
Thank God for them
Yeah,
keeping
thank
me
goodness. Yeah.
regulated.
I know. I just got my pellets like a week ago, and I'd gone, normally it's every 4 months, and cobbler's child has no shoes, so I'm like 2 months past due.
Oh, no.
If I said, Kara, can you pellet me? So,
I keep
and
trying
I
to
could
get
tell the
Tom to do
difference.
it, but I can't convince him.
Maybe
you talk to him on the way out. I'm glad you're here because you've got a bigger platform coming April 12th
Right.
that you're going to be on, and you're going to send me pictures so I can show off.
Yes.
Which would be
Yes.
really cool, which gives me an opportunity to come out before that bigger platform.
That's true.
And to understand what's going on and to kind of set the narrative before Mr. Big Shot, Dr. Drew,
Yes.
sets the narrative. Well, that sounds like breaking news to me, Dr. Bender. You recorded that segment in Brandstar in their studio in Florida in front of a live studio audience. Miramont Wellness Centers' own psychiatric nurse practitioner Samantha Davis and you, the CEO, Dr. John Bender, were interviewed for the segment. And your technician, Brandy McWilliams, applied an Exomin treatment to Dr. Drew Pinsky behind the scenes so that he could experience it for himself. And for those of you who don't know, like me, Exomin is a non-invasive, drug-free brain stimulation that uses magnetic pulses to treat anxiety, depression, OCD, and binge eating during 30-minute sessions. So if you suffer from any of these afflictions, you should really check it out. The segment airs on Fox Sunday, April 12th at 5 p.m. Eastern Standard Time and 3 p.m. Mountain Standard Time, so be sure to tune in. So I have my first question for you, Dr. John Bender, is what do people get wrong about healthcare right now?
I think the biggest mistake that we're doing as a society right now is we rely way too much on insurance to cover our routine healthcare needs. And I don't know exactly how we got into that trap, but I like to give some examples from other things that we insure just so folks can understand it. Like, could you imagine the insanity of being excited about filing claims on your automobile sufficient every year that you could get free automotive? If I can just meet my deductible, I'll get free automotive. No one does that, right? We file a claim every 7 years when we have a fender bender. And then the rest of the time, we fuel the car, we change the tires, we change the oil, we wash the car. We don't file claims for that. We budget thousands of dollars a year for our car. And we'll have several cars during our lifetime. But Dee Dee, we only have one body in our lifetime. Why aren't we budgeting more for our body? Why are we trying to do this insane insurance game to pay for routine costs? We need insurance, but insurance is meant to cover things that are unlikely to happen. When in America, everyone needs primary care. Think of it like groceries. Could you imagine grocery insurance? Going to the grocery store and the checker telling you, well, I'm sorry, your plan doesn't cover T-bones. You get hot dogs,
Well,
well, I
we may
want a
be
T-bone.
heading that way.
Well, it's $3,000 for the T-bone, but the hot dog is 50 cents, They make these ridiculous pricing games to steer our behaviors that aren't even related to what it actually costs to produce the different services.
Well, I remember when I was little, it seemed like there wasn't insurance. Like you just went to the doctor and when you needed to, and then you paid the doctor and then you went home. there wasn't this big insurance thing. It wasn't until I was in middle school that my mother started worrying about, oh, was this in our network and what network we were going to use. It wasn't a thing. We just went to the doctor. So
Uh,
is it relatively, I mean,
I can
speaking
tell you
like
why that happened.
30, 40 years new?
There were two drivers for that, Dee Dee. The first is that a lot of employers were trying to come up with new benefit packages to recruit good labor.
Okay.
And so, we used to produce a lot more here in the States than we do now, and so when we were a very industrious country, getting good labor would require benefits. And if you had a benefits package where you don't have to pay to go to the doctor, that sounded pretty cool maybe to a prospective interviewee. And then also we developed these programs in the late 60s and 70s, Medicare for senior citizens and disabled folks, and Medicaid for people who live below the poverty line. And they wanted to keep those costs down. So they came up with these very low deductibles in case of Medicare or virtually no deductible in case of
Mhm.
Medicaid. And then that started spilling over into the commercial insurance as well, where there was now competition to try to get the first dollar down, at least initially. We're seeing the pendulum swing the other way with higher and higher deductibles. So it kind of reached its peak maybe 20 years ago. Our parents had these $250 Cadillac plans. You'd meet your deductible by February. Then everything was $10. Your baby's $10, your MRI is $10. Now we're seeing a resurgence of $4,000, $5,000, even $6,000 deductibles, maybe $12,000 per family. And the reality is that half of all Americans don't have $6,000 in savings. So even if they hit their deductible, they're probably looking at taking a loan. And the purpose of health insurance isn't even to have healthcare access. Right now, you and I can both call 911. The ambulance will show up. They'll take us to the local cardiac catheterization center. We'll get our cardiac cath. They'll, they're not going to let us die. We'll get our stent and we won't die of our heart attack. But then 3 months later, we'll have heart attack number 2 when we receive the bill from the hospital of $150,000 because now we're medically bankrupt. 7 years, can't own a car, can't rent a place, can't get a credit card, right? So how do we avoid medical bankruptcy? We have health insurance, but it's not for access. You can go get health care anytime you want to at your local emergency room. Not that that's a great plan, and I certainly don't recommend that, but it's primarily to protect our wealth. So our message today is that we should be budgeting for primary care, just like we do for our cars.
Mhm.
Spend the money first dollar on ourselves to stay well. For goodness sake, don't go to a specialist or to the urgent care emergency room unless it's absolutely necessary. And after you've talked to your primary care doctor
Mhm.
who says, yep, this is something that needs to go to a specialist, and then touch that deductible maybe once every 7 years when you have a baby, when you need your appendix out. But at the same time, just buy the cheapest bronze plan you can with the highest deductible and then budget maybe $900 a year for your healthcare, which is less than you budget for your car, by the way, and stay healthy.
Well, that's like one of the things that people don't talk about because they don't know. So we don't have those conversations because people don't understand those things. What's something else that we should be talking about that people don't know? What are we not talking about that we should be talking about?
Well, there's a cool new innovation. And I think of this as a Republican-led program because it's counter to the Medicaid for all idea of the progressives. They want to see everyone have universal health care. The problem with that is, again, I'm a grocer in primary care, right? I'm providing services everyone needs.
Mhm.
And so I really don't want insurance covering those services. It's crazy. If I was a surgeon, it was a $6,000 surgery, file a bill. But when I have to file claims for a $25 flu shot, that is very time intensive and it leads to basically no margin, which is why most primary care doctors here in Colorado especially have sold out to large hospital systems, which only drives the healthcare cost up even more because they tell those docs, turn off your pager, don't take calls after 5 p.m. And then when people call, they hear, if this emergency, call 911, go to the nearest, fill in the blank emergency room that we own and operate on every, street corner now. And that's just driving the cost of care because who's paying for that? We are.
Mhm.
If you go back to the 1970s, there's basically, no offense to Estes Park, but in Larimer County and Weld County, there's basically just 3 emergency rooms, right? There's Poudre Valley, you have McKee, and you have
Banner.
the Banner. Up until recently, McKee closed their emergency room because of some market pressures, I think primarily from UC Health. But we got to the point there were like 10 emergency rooms, and did we really need that many emergency rooms? Really what people need is a way to get in with their primary care doctor today, not go to the emergency room. I mean, emergency room's convenient. The ambulance will pick you up. I don't come pick people up at their house. But once you're at the emergency room, they don't take you home. It's a one-way ticket. And it can be up to a 6-hour visit. And it's going to be a $5,000 bill. Even if it's an IV or something I can do in office, my bills are never thousands of dollars. They're going to be hundreds of dollars. So how do we get those costs back down? Well, we have to just avoid the deductible. So there's this new innovation called direct primary care, and Colorado has been on the forefront of this movement for about 10 years now. Some of the thought leaders like Clint Flanagan with Nextera, Peak Med down in Colorado Springs, ourselves, Miramont Wellness Centers in Parker and Fort Collins. And what we do is we offer a subscription-based model. So we tell people, pay $85 a month, join us like a gym for all the healthcare you can treat. And then we still want people to have health insurance because they need to be able to protect their wealth. We talked about the reasons there. It's not for access, but to protect their wealth. But just don't touch your deductible. And then we've tried to cram in as many services as we can to keep you out of specialists. So we have in-house lab, x-ray, mammography. We do colonoscopies. I was doing those this morning I don't actually do the colonoscopy. Dr. Dickman comes up and does those, but we give people sedation, that kind of thing. And we have a med spa. We do urgent care services. We cast, we splint. So if someone breaks their foot, I'm not sending you to an orthopedist. I'm going to cast it. I'm going to have my physical therapist see you. We're going to rent you the crutches. We've got all that there. We've got our small retail store that allows us to dispense medications because in Colorado, if a physician gives you medicine, it's the practice of medicine, not the practice of pharmacy. And then only if it's like an angulated fracture that needs a pin, then am I going to send you to a specialist. And even then, I'm going to call people I know who have better pricing that are willing to work in ambulatory surgery centers, which are much more cost effective than a large hospital system. So for example, we had a young lady who broke her elbow. And the entire cost of her surgery to get that done was around $18,000, which is a fraction of what that would have been in a hospital system. And so we're very proud of that. The hospitals are doing very well. They're nonprofit, but make no mistake, no profit doesn't mean that they are poor or that they're necessarily benevolent. They have great reputations, and I'm not trying to disparage anyone, but in our state, UC Health, for example, has a $7 billion surplus. I'm going to say that again, $7 billion surplus. And
It's a lot of billions.
They don't pay taxes on it. The state legislators has come up with this limit of what they're allowed to keep. And if they were building primary care offices that allowed you to get your sick kids in, same day or whatever, that'd be great. But they're not. They're building cancer centers. They're building freestanding emergency rooms. They're building cost drivers. And as they become wealthier, then it's harder for competition. That's why Banner, had to give up doing OB. It's why they had to give up their emergency room. That's not good for West Loveland because now people have to drive an extra 15 minutes to get to the hospital when they previously maybe were in their neighborhood. And so, and again, UC Health does incredible things. I'm not trying to disparage them. I'm just the messenger here, so please don't shoot me.
I'm not.
People need to know this information, though.
No guns down here.
Yeah, no.
They're up there.
But I'm saying it facetiously, of course. And if that happens, I do want you to take me to UC Health because they have the trauma center, and my daughter is one of the nurses there, and they're going to take great care of me. But my point is, we have to think as a community: is it really wise to let nonprofits have $7 billion in surplus? Is it really wise that they're not paying taxes? That people look at me and they might say, well, Bender, you're a for-profit organization. You're profiteering off people's, disease and sickness. I mean, that's a very cynical way to look at healthcare. I went to healthcare because I like to help people and I like to see transformation in lives. I don't like handing people a pill bottle and saying, here's some Lipitor, now you can eat anything you want to. You know, my goal is to help them lose their weight, quit smoking, and get to the point where they're using food as their medicine and eating their way to a normal blood pressure, a normal cholesterol, and normal blood sugars. And we do that all the time. I've got people who have really seen improvements in their cancer just by changing their diet and their exercise routines. So that's my role in the universe. But I'm paying taxes on all that. You know, so my property tax bills are insane. You know, we spend $30,000 on the Snow Mesa building. We spend, $50,000 on the Drake building. We spend $30 on the Parker
And these
building.
are small buildings. These aren't, it's not
They're
a huge
small
medical
condos.
complex.
Yeah,
This is
these
a
are small
building.
condos. And yet there's 3 other condos in the same block owned by the hospital. And don't take my word for it. Go to the Larimer County Assessor site. They pay zero. They pay they're not paying for police, fire, teacher. I am.
Right. And then there's a campus across the street that's acres and acres and acres.
Right.
And also paying zero.
Right. Meanwhile, I have to figure out the math of how do I keep x-ray techs on staff? You know, that's an area that's just crazy. I mean, 8 years ago, I could hire an x-ray tech fresh out of school, probably $22 an hour. I got to the point where I could give them raises to $50 an hour and they'd still quit to go work for a hospital system or to do like a traveling program. It got really bad during COVID. And so as the labor gets pulled out of primary care, it becomes harder to keep the doors open, right? And yet again, is it really ideal to have to drive 5 different places, here to get your blood work, here to get your x-ray, here to, I mean, my office, people park and they walk in the door. At these big hospital centers, you're going to park maybe in a parking garage. You're going to walk 3 blocks. You're going to go up an elevator, you go down the, and you might be in with crutches, walker, wheelchair, stroller.
Well, then you have to sign in and then you have to navigate. You have to find your way. You have to do all of those things.
It's hardly
And then you have to wait.
And you're not going to get the blood result while you wait. You're not going to get the x-ray report while you wait. We do in my clinic. So much more efficient. But I saw as primary care offices were closing, because back in 2000, when I was first starting out, I had 1 employee, 1 computer. We grew to 7 office locations, 95 employees at our peak. And the reality was that other doctors were just selling their offices and becoming hospital employees. And the first thing the hospital system would do is say, well, we're going to shut your lab down. We're going to shut down your x-ray because they'll go to the hospital now for that. Well, now they're charging facility fees and other things, for services there in their building that again became big cost drivers. And initially insurance companies are paying that. But even the insurance part, and this is another thing I should share with the viewers because it's really interesting. After the Affordable Care Act, also known as Obamacare, there were caps put on how much insurance companies could earn. So they ended up with this little ratio, and I think it was around 15%. Well, the only way that they could continue to increase their earnings per share if they're traded on the stock market would be if they kept having higher overhead costs. So if they paid more out in claims, then they could take a bigger profit. So now they had this incentive to actually not rein in the cost of healthcare, but they wanted to do it very specifically in ways they controlled. So they like paying big pharma, for some expensive meds, they like paying big hospital systems, but they didn't always like paying primary care. And so we started to see a widening gap between what primary care doctors earned. And largely, primary care is being replaced by physician assistants and nurse practitioners. They have great skills. They don't have my skills, though. They're maybe not going to be able to reduce a shoulder or set a fracture in a cast or do some of the skin cancer surgeries, take off a melanoma, that kind of thing. So it has become sort of a race to the bottom where we're paying more and more, but we're driving it to these more inefficient type systems. And a lot of it just comes down to the simple concept. We should not be using insurance to pay for primary care. We should be budgeting for primary care like we do our cars, and then only touching insurance when we absolutely have to.
No, I like that model. I like that a lot. How long have you been in medicine?
Well, I graduated medical school in 1992. I was a Navy flight surgeon, so I served for a number of years. They paid for my medical school, which was nice because I didn't have medical school debt. My wife, Teresa, and I moved 17 times in our first 17 years of marriage for medical school and the Navy. And then I was in the Army after that, served in Kosovo. But we have been settled back home where we're from originally, Loveland, and we've got 9 grandkids, so I don't think we're ever leaving. And I enjoy what I do. The company, Miramont Wellness Centers, is employee owned now. We are an ESOP, or Employee Stock Ownership Plan company. So 30 of our 65 employees own a third of the company,
Mhm.
and that's created some stability for us, and it really makes for a great camaraderie and a great culture.
So you've been on kind of both sides of medicine because you worked in medicine before. You
Mhm.
were in
Yep.
direct primary care, right?
That is correct. I was an employed physician,
Okay.
both by the government and by hospital systems and by independent clinics.
So when did you see the big shift? Was it Obamacare? Was it before Obamacare? Was it as you described before when you saw insurance kind of chipping away and taking control?
So the answer to all that question is yes, yes, and yes. So uh, again, in 2000, no physicians were hospital employees. I mean, virtually none. Every
Mhm.
cardiologist, pulmonologist was independent. They all became absorbed by hospital systems. You really don't see much independence in some of those critical specialties anymore. Uh, some specialties have stayed independent: dermatology, plastic surgery, some orthopedics.
What about pediatrics?
Pediatrics is hard. They are largely getting consumed.
Okay.
There's a few fiercely independent, but they have to work hard, especially if they want to vaccinate, because the margins on vaccination can really lose your shorts vaccinating, just because what the costs are for some of the newer vaccines. Parents don't want their child poked 50 times. They want everything
Right.
crammed into one vaccine. That those are usually brand name, not generic. So that becomes a problem then of how do you vaccinate kids? And I realize that there's a lot of controversy about vaccines, but I mean, publicly, I'll just say I still think we should vaccinate against polio. We wiped out smallpox, folks, in the 1970s. That disease is gone, and that used to be one of the largest killers on the planet. You could argue it wiped out 90% of the Native American population. Not intentionally, but that
Mhm.
happened. That's real. Uh, the smallpox the smallpox vaccine stopped that. We could eradicate polio. We're really close to it. The problem is that polio largely exists right now in nations that are hostile to us. And so it's hard for groups like Rotary and that to go in and get us fully vaccinated. But if there's a chance of wiping out a disease so that no one ever dies from it again, we should be vaccinating against it. And then for children in particular, there's certain things, we don't want them getting measles, mumps, rubella. They get some of these, it might make them sterile. They can't have kids. That's not fair to let a child have to live with that when it's completely preventable. But going back to your pediatric question, most of the pediatric and med peds clinics in northern Colorado have become part of hospital systems or a children's hospital.
So even they're not standalone anymore. That's so sad. My children's pediatrician he was independent and on his own, and I
Right, but
really
this drives up
appreciated
costs
that.
because, again, if you pick your child up at school and teacher goes, "Well, little Johnny's sick, probably shouldn't bring him back in tomorrow," or, "We think he has pink eye, you better go get that checked out." You start looking around, no pediatrician's open. I mean, my office is open till 8 p.m. You can see
Right.
us till 8,
Mhm.
but most offices, they're owned by the hospital systems, not open. They're gonna drive that to urgent care. They're gonna drive that to the emergency room, and again, that gets scary expensive, and who's paying for that? All of us. Even if it's a Medicaid patient, the Medicaid patient may only pay $1 or something, but it's coming out of our taxes. Every time you get
Yeah.
your
Yeah.
your pay stub, you see the government takes a big bite, right? Well, a lot of that's going to healthcare.
Mhm.
And the crazy thing is if we eliminate the waste in healthcare, there's actually enough left over for every man, woman, and child. I mean, you could argue our deficit, and I lost track. People are going to laugh at me because I used to use the number 21 trillion. I know it's way higher than that now. There's like little counters. You can watch how fast it's growing.
Mhm.
But roughly half of that is probably due to healthcare waste.
Well, I was talking to one of our favorite candidates recently, and she was telling me that here in Colorado, our Medicaid expenses have gone from 35% of our total budget to 50% of our total budget in
That's right.
Colorado in just the last few years. But our number of Medicaid recipients has gone down. So we have fewer Medicaid recipients, but we've increased 15% in our Medicaid
That
spending.
program has been mismanaged completely, and, I mean, I know that there might be some viewers that would take offense to that, but I'll just give you some true stories. I can't make this stuff up. I told you at one point we had 7 clinics.
Mhm.
Part of the reason we closed the clinics is that initially, when I when I had clinics in Red Feather Lake, which we were the only clinic in Red Feather Lake, when we had the clinic in Wellington, which we built, we were the only clinic in that community for years. This is a bean farming community, and it was very rural at the time. We had the only clinic in Fairplay, Colorado that we were operating, and it was the only clinic in all of Park County, in the entire county, okay? And we expanded and took those risks going in West Loveland, arguably was about 50% Medicaid. That was a part of the state for us to be working in at the time. When we first went in, the state had expanded Medicaid, the federal government had expanded Medicaid, so they were paying the same as Medicare. So just to give you an example, if we say that Medicare is paying $1 on a dollar, Medicaid was paying about 79 cents on the dollar. And then they gave us what was called the primary care bump. So they said, we're going to give you a 21-cent raise. And if you can make money seeing Medicare, then you can probably stay in business seeing Medicaid. We said, fine. We grew from 1,000 to 7,000 Medicaid patients. And the state expanded coverage. At one point, I think it was like 1 in 4 Coloradans was on Medicaid. It was a big expansion. And there were progressives who wanted to get everyone kind of Medicaid for all was going to become our universal health care, right? That was their push. Well, then at some point, President Obama is no longer president, and Congress says, we're not funding this anymore because it was an appropriation, not an entitlement. See, Medicaid and Medicare by themselves are entitlements. That means even when the government gets shut down, I may not get a check from Medicare for the work I'm doing today, but at the end of it, just like those TSA workers aren't getting paid, we do get paid eventually. I might have to go float a loan from my bank until, make my payroll, but eventually Medicare is going to make us whole. It's just like waiting for that IRS refund check. It is going to come. It's just getting delayed because of the shutdown, but it's an entitlement. The bump was an appropriation, which means Congress can say, we're not paying that for this year. It's legal for us to pay it, but we're not going to do it. Well, the appropriation stopped. So then Governor Hickenlooper stepped up and said, you know what? We're committed to primary care. State's going to pay for it. So the state picked up the bump for 2 years. Thank you, John Hickenlooper. But then we had a budget shortfall, $500 million, just like we have a huge shortfall this year, which is way higher. And that was the first thing John Hickenlooper got rid of. He's a sitting governor. I'd met him, and had a beer with him, but he signed it and he killed it. And my margin, Dee Dee, was 5 cents on that dollar. That means when we took the pay cut from $1 on the dollar down to 79 cents on the dollar without the bump, I started losing $250,000 a year in Red Feather, $250,000 a year in Wellington, $250,000 a year in Fairplay, $250,000 a year in Loveland, West Loveland. And our clinics in Parker and in Fort Collins, which are wealthier communities, much more commercial insurance, much more people willing to pay a monthly subscription fee or do retail. They did fine, but we had no choice but to close those clinics. And here's the crazy thing. They expanded Medicaid cards at the same time. So they gave us a cut in Fairplay that made it impossible for us to keep the only clinic in the entire county open. And yet they increased 10,000 Medicaid beneficiaries. So here they gave all these cards. Look at this. We gave 10,000 people in Park County Medicaid cards. They don't have a doctor.
But they don't have money.
You have to drive 90 minutes east to get to, West Denver. And so if you're really sick, can you drive that far?
No.
If you're dizzy, it was just nuts. And the logic in that, that just, and I realized the optics was great. Oh, look how we gave all these people coverage. They gave them coverage, folks. That's insurance, but that's not the same as access. Remember, we started this podcast making that point, that access isn't the same as insurance. Insurance is not access. Access is a doctor that you can actually get to, and it's probably one that you're paying for firsthand. So we became disenchanted with Medicaid very quickly. We still see Medicaid, but we pared down to about 1,000, and we have 1,000 Medicaid patients. We're not accepting new Medicaid at this time. We see people that have been with us, and if someone loses their job and no longer has their Blue Cross and now is on Medicaid, we're going to see them. Or if they get married, we'll see their spouse. Or if they have a child, a lot of children are on Medicaid, we'll see their children. But we're just not, it's just not cost effective for us.
Right.
We have to see a certain number, about 24,000 commercially insured patients to be able to afford to see 1,000 Medicaid patients at a loss. And that's the math. Our legislature doesn't understand this. They could do so much better in funding primary care that would make it sustainable. I would open all those clinics back up overnight if they gave us back the bump.
Well, I've been on calls with you with legislators, and listen to you explain it to them. And you've explained it to them very simplistically and not and they just don't want to hear it. So I don't know that it's that they don't want to understand it. Or that they don't understand it. I think they don't want to understand it.
I was trying to be kind, but yeah.
Because I've been on those calls and I'm not a financial genius, but I understood exactly what you were saying.
Yeah, the reality is Medicaid is supposed to pay for health care, but they want to use it now to pay for daycare, for food, for social determinants of health. And I don't like the development of the nanny state. I don't need the government to coddle me. There are citizens in our society that, they're having a rough time and they need some of that. But do we want a whole society like that?
No.
I mean, as a child,
in my opinion,
no. As a child, roughly 10% of our population in Colorado, this was in the 70s. I've been here since 73. Roughly 10% were on Medicaid, which meant about 10% of our population was poor. Well, if suddenly a fourth or trying to press for a third of the population is on Medicaid, what's that saying? That's not a great state. That means mass poverty, right? And government reliance to an extreme that makes people not interested in making choices to get themselves healthy. It's easier if the government's just going to give you a free pill, but we would try to see Medicaid patients for weight care. They'd say obesity is not a disease. But if I could help them with their weight, they would get off their meds. That would save money, but they didn't want to pay me to do that. And I can't perjure myself. I can't make stuff up in the medical chart. And they're not willing to pay cash. In fact, they have crazy laws here in Colorado. Like, I can't charge Medicaid patients extra for my services. So if the Medicaid patient comes in and says, well, Dr. Bender, I know Medicaid won't cover it, but I want to pay you to do it. I can't do that. It's against the law. Now think about the insanity here. If they want to go to, let's say, a shaman or go to acupuncture or a chiropractor, they can do that. But if they want to come see me for healthcare, it's unprofessional conduct for me to do that, to charge them extra. Does that really make sense?
Can you just open some shaman services?
I worry about the Board of Medicine.
No, I'm teasing. Don't do that because I know they're already
what I think
you.
I'd rather do is spend time with the legislators and, maybe they need to be picketed a little bit, but it's crazy how they've spooled up the system and they say they're pro-primary care, but I'm primary care. I'm telling you right now, legislators, you are not primary care pro. I can tell you that right now. If you want to learn about primary care, come spend a day in our office. We'll put a white coat on you. I'll introduce you as a guest and see how medicine really works. Because I actually do it in the trenches without a large hospital system backing me. We haven't had to sell out. We're fiercely independent. We take care of people. We offer wellness. We have outstanding outcomes. The public has voted with their feet. We have 25,000 patients. We're 4-star on Google.
And there's no wait times. You don't wait. You go in, you sign in, you go to the room, people come, they take your blood pressure, they take your with the oxygen level, they take your oxygen, somebody comes in, you see him, and bada bing, bada bang, you're not there for more than 30, 45 minutes.
It can be fast.
And he has conversations with you too.
We try very hard. There are occasionally waits. We had some really bad winds the other day, and a poor lady got blown over in her walker and hit her head. And
well, that's an exception.
Doctor in my group was out there, and I think we got a 1-star review for being 30 minutes behind. But that's
30 minutes.
I will drop everything to take care of you if you hit your head. I promise you that.
I had one pediatrician where you waited at least an hour and a half to 2 hours to see him.
Yeah,
it was ridiculous.
It's never that long. Never that long.
No, it's wonderful.
We really try.
And I just found out the last time I was in your office a couple of weeks ago that you had profit sharing in your office.
Yes.
And I was like, well, that's why.
Yeah.
Everyone's so happy and friendly.
The employees
and you
get
don't
their stock
wait.
certificate. Our goal is to keep that rising because that's their IRA. Yeah. We're self-funded for health insurance. I don't buy Blue Cross United. And then when my employees get sick, we pay the bill after their deductible. And then we have reinsurance, which is legal in our state. We self-fund for short-term disability, and then we self-fund for our retirement plan.
No, I think it's fantastic. So question about direct primary care.
Yes.
Is direct primary care a workaround for insurance, or is it a threat to insurance, or is it neither, or is it both?
I would think an insurance company would love direct primary care. And I'll tell you why. I'm still in network with Blue Cross and other insurance companies. Not all of them. I'm not in network anymore with United. But with the insurance companies I'm in network with, All they know is that for years I sent them bills every day, and suddenly their claims experience with me is outstanding. They don't get bills from John Bitter anymore, right? They get bills from the specialist I refer to, and if I
Mhm.
send someone to get an MRI, they're going to get a bill for that. But the patients themselves are paying the first $900. I would think that that would be something they would really be happy about because it's decreasing their overhead. But again, they like to spend more every year because that's the only way they can keep showing ever rising profits to please their shareholders. So that becomes sort of a problem with the way Obamacare is structured with what's called the medical loss ratio. That was what I was trying to think of earlier, the medical loss ratio that limits them to how much they can earn. These ideas sound good on paper, they really don't make real world sense.
No, no. So there are a few direct primary cares in Colorado. When I was in Florida visiting my mother, I was telling her about direct primary care. She and her husband have a concierge doctor that they use.
Mhm.
And so we were looking into direct primary care while I was there. Is this something that is spreading across the nation, or is it pretty concentrated in certain areas?
As far as I know, there are DPC in every state in the United States now, and Washington, DC. There's a great resource that a gentleman by the name of Dr. Phil Eskew puts out. It's called DPC Frontier. And so if you just type the letters dpcfrontier.com, it takes you to his mapper. And Dr. Eskew has done his best to try to map out every single DPC in the United States.
Oh,
And he
wow.
further classifies them whether they're a hybrid like Miramont. So we have about 25,000 traditional insurance patients. That includes the Medicaid. And then we have about 1,200 on our DPC program who join us like a gym. Um, so we're a hybrid, but there are some that are pure DPC. They only do the DPC model. There are some that are more concierge, and what that means is they still bill the insurance and they charge you an access fee. And that's not always legal in every state. It depends on different states. We've avoided that at Miramont. We still want to provide a white glove experience,
Hmm.
but I really don't want to be billing insurance for my services for all the reasons that we explained earlier.
Okay. So that's the difference between direct primary care and concierge. Is concierge still kind of does
Yeah, they're a
insurance?
little more likely to be like the MDVIP is a good example of that. People
You
pay.
say that again. The what?
It's called MDVIP. So Dr. Bob Homburg and a couple others used to have an MDVIP program here in Fort Collins. I think when he retired, it went out of business. But they charge, I believe, their members $1,500 a year,
Hmm.
which is quite a bit higher than what I charged. They still build the insurance. They didn't have in-house lab and X-ray, so I'm not sure what the draw was. We try to be very competitive. We want this to be cost effective for as many
Hmm.
Americans as possible.
Yeah. And you have a discounted rate for kids too, right?
We do. So children pay are $15 a
Yeah.
month. We don't allow unattached minors. You can't sign a child up by themselves. They have to be
Right.
attached to an adult.
Right. Yeah. Because I had my stepdaughter
Mhm.
sign up for a little while there, and her mother died because she was on Medicaid through her mother. And then when her
Uh,
mother died, she was like, "What do I do?" I said, "I got you." So I just brought her in
we call that
under
Medicaid
me.
churn. Medicaid has a high turnover of people coming into Medicaid and out of Medicaid and month to month. And this is also problematic because we've had folks come in, they lose their Medicaid for a month, maybe through no fault of their own. And then for that 1 month, they got seen. Now they have a huge bill with us. And then, we're trying to decide, do we send them to collections? We don't like sending people to collections. But at the same time, if people are coming in and we're not being paid, eventually that's coming out of my employees' bank accounts
Right.
or, so it's, we can't do the work for free. We wanna do the work at the best price possible for the best outcome possible and for the most access possible. And I think we're balancing that about as best as can be done in this economy and with the regulations we're given.
Those regulations. So other than our fabulous state legislators, who doesn't like direct primary care? Who would be against this model?
So I think the hospital systems have kind of toyed with it. I've seen them try to offer something like DPC, but at the end of the day, I can lower healthcare costs substantially. And we know this because I participate in what's called an accountable care organization. So in our ACO, we do one with Medicare and with Blue Cross. If I do something brilliant and I keep a person out of the hospital, let's say we catch an early pneumonia or blood clot, we start treating them as an outpatient because a lot of times we will,
Hmm.
because I can start the IVs, we can start the blood thinners, we get the CAT scan as an outpatient, see they have the clot, but they're not tachycardic, they don't need to be admitted, and we're managing it all as an outpatient. Well, had they gone to the hospital and gone through that whole routine, that might have been a $75,000 bill. So here I saved the system $75,000, and yet I get paid $100 because that's what a 99214, routine office visit pays. Because that's all the insurers is going to pay. They go, well, you spent 40 minutes with the patient. That's what we pay for a 40-minute visit. Doesn't matter that my team saved $75,000 that day, right? So what the Accountable Care Organization does, Dee Dee, is they say, look, we know on average we're going to spend about $10,000 per person. And if we see that you're costing us less, we're going to give you half of it. And so Medicare does this, but they give half of it to the ACO, and the ACO gives us half of that. So we actually
Chicken
get
25%.
25%. But our ACO payments last year were $400,000. So that's another way of saying, and that wasn't for all 25,000 patients, because only about maybe 4,000 of our patients, or about a fourth of our patients, are enrolled in the ACO. That's another way of saying that we saved $1.6 million on a fourth of our people, which means we might be saving about $4 million a year. So imagine if a hospital system puts in a DPC. Well, where does that $4 million savings come from? It comes from their cath lab. It comes from their ICU. It comes from their emergency room. They're losing money.
So they're not going to like that
There's
at all.
And remember, they're nonprofit. You would think they don't care, but they've got a $7 billion surplus. They do care.
Yeah.
So it's a hard, it's kind of like why Kodak couldn't ever bring the digital camera to market. They actually invented one of the first prototypes, but they were making so much money with Photochrome, and they're like, well, we're not going to stop selling film. And it wasn't until it was too late, till others had come in, Canon and others with digital cameras. Now Apple and Android, is where your camera is. And so they got Kodak. That's now a word in the industry. Well, a hospital system, they can't really disrupt themselves. It's going to probably have to be an external force like the DPC movement, but it requires buy-in from the population. If people are like, well, I like the security of the hospital system. I've got a lot of health problems. I need my specialists. But you'd be surprised how many people, I work on them for 2 or 3 years. They're not seeing the specialists anymore. They come to us and we're like, well, you could do, if you lost 50 pounds, like your knees would stop hurting. You would not need to go, So we work on that. And it might take 2 or 3 years, but over time, we see them get healthier and healthier. And I give every patient my cell phone number. And there are people who will abuse that. They'll call me a lot, but I don't mind, because what I tell my nurses is that's the universe's way of telling me this is the person you haven't fixed yet. Figure it out. Go read some more. Bring them in some more. Study them some more. Maybe I do need a specialist consult. And then I'll look back, 10 years later, and I'm like, this used to be one of our problem patients. We never see them anymore. They come in once a year for a physical. You know why? Because we fixed them. And they fixed themselves. I mean, it's a cooperative.
They finally listened.
Yeah, but they quit smoking. They got off the drugs. They lost their weight. They started exercising. They did some mental health stuff. Get out of their funk. They're not suicidal or depressed anymore. And they got a good paying job. And they're in a stable married relationship. And they're producing in society. And for those, and not every case ends that way. I mean, we had some drug overdoses over the years. We've had people we've lost. It's not always been pretty. But for the ones that have come out, those have been the majority. And that's really what motivates me. That's why I'm almost 60. I don't plan to retire another 15 years. As long as I'm able-bodied and have my mental faculties, why would I do that? I love what I do. My staff love it. I want to be there for my patients. And so we're having a lot of fun. I mean, we see some stuff that's really sad and scary, but we put it in perspective and we go, okay, what are we going to do with this to get this person to and that's why we changed our name from Miramont Family Medicine to Miramont Wellness Centers, because I'm like, I'm not doing sick care anymore. You can be sick all you want, but we're going to figure out how to make you well. And we're going to get you to a point of wellness where you don't want to be sick anymore. You're going to maintain wellness, and it's going to be about that. I mean, still get a sinus infection or something, but we're going to nip that in the bud because you're going to have access to us on the direct healthcare app, which you can message your nurse, my nurses, or your nurses, however you want to look at it, and myself, and we're going to get back to you. And so we've tried to create this digital healthcare ecosystem that's real time, that allows people to have access to their doctor. But the punchline is we want people to be well. I really don't want to put me out of business. I want everyone to be so healthy they never have to come see me anymore. That's really the goal.
Yeah, well, as long as you've got hormonal women like me, you will always be in business. Well, we will always need our hormones.
Hormone balancing is a big part of our premise. So I should probably give a shout out to BioT here. but they are happy with us because we're the second largest producer of hormone replacement for Biote in the state of Colorado. And this has really been transformational. And people ask me, well, is pelleting natural, Dr. Brennan? I go, no. What's natural is to live to be 50 years old, go through menopause, and then die. Because that's what people did 200 years ago when life expectancy was 50. Now we live to be 87, and we expect to be sarcopenic, which means no muscle, osteoporotic, which means no bone, no libido, vaginal dryness, brain fog, can't sleep well, irritable, edgy,
get chubby,
no stamina.
No sleep.
Yeah, start redistributing fat in ways that doesn't make us feel good about ourselves. And so that is all optional now. And not everyone can do hormone balancing. We have to bring you in, do some lab work. But the vast majority of Americans are good candidates for it. And no one's ever come in and said, I want the pellets out. I mean, we use little pellets about the size of a grain of rice. They go up high, kind of in the hip area, buttock area. And they last for 6 months. We usually replenish them every 4 because we don't want people to go all the way back down to 0 on their hormones. But it really does improve quality of life. It improves stamina, energy, improves muscle mass. And so we're all about that. We do a lot of weight care, and we have a number of different things. Even if people have failed the GLP-1s, the skinny shots, we have other solutions for them. I mean, we were helping people lose weight long before semaglutide was out there. But if they need semaglutide or tirzepatide, we can get access to that for them as well. And we do our darndest to make it cost effective. And so we have a number of different ways to do that. But that really is the secret sauce, is getting people to that state of wellness to where they're so motivated, they don't want to ever go back. They're like, I don't want to go back to where I was, my COVID weight, where I was 20 pounds heavier. I don't want to go back to where I wasn't exercising and doing some activity. I don't want to go back to smoking. They're focused on keeping themselves well because they love how they feel.
Yeah, well, you said to me once, nothing tastes as good as skinny feels, and I will never forget that.
It's kind of a bad joke, but
you're stuck with me.
Yeah, every little thing to help. Every little tool.
In addition to all of those things, you have a very innovative clinic. I mean, you've got automatic pharmaceutical dispensary. You've got dispenser. You've got robots running around your clinic. You've got
so almost 10 of our employees work from home, and we have 4 of these robotic devices, and it's primarily used by our scribes. So we have Kayla working in Massachusetts, Jeanette sitting at home in Ohio, and they're going to beam in, is the word we use it, and they can drive this thing. It looks like a Segway on wheels, and it's got a little monitor, but it's very interactive. And people say, why don't you use like a Dragon Speak? Can't you just have Chat GPT listen to the visit and do the note for you? It's like, well, no, the scribe is doing so much more. They're doing care navigation in between visits. They're helping the patient go through the care plan a second time, providing coaching support. They're actually a second set of eyes for me. It's like a co-pilot, because every now and then I might skip something and they'll kindly turn and say, Dr. Bender, didn't you also want to start them on X? Oh, yeah, that's right. We need to do that. So, it allows us to be safer, to have less errors. Plus, we used to have doctor handwriting. No one could read it. Now we have doctor typing, I type and it's like, what was that word? They go in, they clean that up for us. And then they make sure the coding and billing is correct on the insurance side. So I don't see it getting replaced by AI anytime soon. I mean, there's a lot of work that, I'm not saying it wouldn't be impossible, but people love Janessa and Kayla. They're not going to want to talk to a robot in place of that.
No, I really like them. And one of them was in the office before she went remote, and she got married. So we had a personal relationship, and then it was fun to see her as a robot because I didn't lose her when she moved away.
Well, and so just for full transparency, none of my remote workers started remote. They all worked in the office, and at some point moved to Cheyenne, Texas, Arkansas, where we've got some people now. And we let them keep their jobs because they were good at what they did, and we came up with a solution. And in COVID, everyone had to learn how to work remote, so that kind of worked out. But it's exciting to innovate. They say you never want to be the first nor the last doctor to try something, So, but we try to stay current on the latest medications. One of the most exciting innovations that happened here recently is in our liposuction program, because we're doing conscious IV sedation. There's some risk with that, because with sedation, people can have reactions and things that can be harmful. And so sometimes that's even more of a risk for the person than the actual liposuction procedure itself. Or there's this new miracle drug called Jernavix. This is a brand name. It's only available brand name. And the way they learned about it, Dee Dee, is they studied this group of people, this family, that they couldn't like feel pain, which isn't a good thing because people break
No,
bones and they
there
can't
was a
feel it.
movie about
Yeah.
that. Yeah.
And so the researchers identified a new sodium-gated channel in the spinothalamic tract that modulates all our axial pain and our facial pain.
Okay, now say that in English so people understand what you just said.
So basically, we have a brain and a spinal cord, and all the pain has to go through the spinal cord or through the cranial nerves to get to the brain. Otherwise, you don't perceive it as pain. And it uses these little electrical channels to propagate the wave, just like electricity down a wire. Well, they found out that there's this special channel that we didn't know about. And then the scientists created a medicine that blocks it that's not harmful to humans. In fact, you can give it in practically every state. Most liver failure, most kidney disease, people can take it. It interferes with birth control pills, but most medicines it doesn't interfere with. But it blocks the pain completely for about 24 hours. We do a dose the night before, a big dose on empty stomach. Then we do a dose the morning of. And they basically can be on the table or doing the liposuction and they're feeling almost nothing. I mean, it's really incredible. It's been such a game changer. So we adopted that in October. I've used that medicine now probably about 30 times, and it's given us outstanding outcomes. But I talked to a lot of specialists. No one's heard of it, and it was just kind of like I went to a medical conference, learned about it. So we were probably one of the first to bring that medicine to Fort Collins, and it's horribly expensive. But we were able to source it through some of our online supply chain, I guess.
Mm-hmm.
And what we do is we just sell people only 3 pills for like $60, and that allows them to then have these procedures that otherwise are pretty uncomfortable. But now we have people fall asleep during their liposuction. I mean, it's crazy. And it's safe because they're not under sedation. We're not giving them fentanyl or anything like that. They're comfortable, and then they wake up and they can actually drive themselves home. We give them a little nitrous oxide and some other things too. But I like being on the cutting edge with the innovation. And then our direct health app, our telehealth app, we have source coders in-house that actually do the programming on it. We're working to turn it into a full patient portal so that people can see their lab results. That's coming this year. They're working on it. But just, a lot of fun. You mentioned the robotic vending machines. So we have no controlled meds, but we have prescription medications, and it's basically a secure storage locker, but allows people to go to the machine, swipe their card. If the machine can vend the pills because the bottle's the right size, it'll come out. If not, they get a little claim check ticket. They bring it to the front desk, and then they dispense the medicine to them. And that's legal in Colorado. And in Montana, in Texas, there are only 2 states where physician dispensing is not legal, but 48 states, Guam, Washington, D.C., it's legal.
No, wasn't our legislature trying to give you a hard time for that at one point?
Well, so I mean, I don't know if it wouldn't be me personally, but there's like 5 laws right now that are coming out that the thing about making laws is you never know how the regulators are going to interpret them after they're done. So, for example, I wrote most of the direct primary care bill that made DPC legal in our state. So prior to Governor Hickenlooper signing that bill off, that the Colorado Academy of Family Physicians and others worked on, the DPC coalition, it didn't say whether direct primary care was legal. And my concern was that the insurance commissioner would say, well, are you collecting $85 a month from people? Oh, yeah. And then when they come in, you provide them services? Oh, yeah. Well, that sounds like insurance to us because you're charging them a monthly premium and then you're giving them a benefit. But to do insurance in our state, you need to have a risk pool of $20 million. Where's your $20 million? And so it's not that DPC was illegal, but I wanted it in statute that it was not the practice of insurance. So we did that. We had to say it's not the practice of insurance. And that got signed into law. And I think 99 out of 100 people voted for it. There was one legislator who did, because there's 35 in the Senate, there's 65 in the House. And it had bipartisan support.
I'll bet I know the one. No.
Yeah. I think it was Kevin Lundberg, but
no, that's not the one I was thinking.
He did it for
really.
He and I love Kevin,
I do too.
but he had some philosophical thing. I can't remember what it was,
so
but and he can't turn his heart.
Sorry, Senator.
I love Kevin. I just saw him the other day at the GOP county.
Oh wait,
convention.
We're disconnecting here. We may have to reconnect. Hold on. Okay, it's back. Sorry.
Okay, but But what happened is it wasn't the practice of insurance. Remember, we discussed earlier, Medicaid is insurance, right? So if DPC isn't insurance, then people on Medicaid could sign up for my program. So we had about 85 people who were on Medicaid sign up for our program. And why could they do that if they're poor? How could they? And our rate then was lower. It was $59 a month because like 10 years ago. Well, it's because we had expanded the program, so the new Medicaid were healthier and wealthier than what they used to be. And some people had real world problems. They were drug addicted, needed to be on Suboxone, couldn't find anyone in Denver, and were willing to drive up to Fort Collins to get their care. Well, a state regulator came out one day and said, "Oh, this is illegal. You guys can't do that." And I said, "No, no, no. Look at the DPC law. It's signed into law." And they said, "Well, I know what that says, but this is how we interpret it because this is what we think they intended." I go, "I wrote the bill. I know what we intended." But they were able to just change with the stroke of a pen how it was interpreted, even though it was written in plain speak English. And so we had to disenroll 85 Medicaid patients that year all at once. One of them was on Suboxone, ended up back on heroin and died. So I literally think that decision killed someone. I'm willing to say that publicly. And so, yeah, there are times when the legislature, does their best, but then the regulator comes in and changes how the law is interpreted. And that's because the only way you can fight it then is in court, right? You need to have a judge come in, or you go back to the legislature and try to get a new bill, an amendment, that says, hey, this is really what we meant. Stop doing that. In this case, it was, our health department, not the health department, but the I'm blanking on the name of the group that oversees Medicaid in our state, HICPUF, Healthcare Policy and Finance, had made that decision. There's some bills this year to make compounded semaglutide illegal. That would be crazy. There are thousands and thousands, car rounds who are on it, and it's very safe. It needs to be medically supervised, though. If they're buying online, that's a problem because if they're doing it on their own. My daughter works at Medical Center Rocky. She tells me, "Dad, every week we have someone with a bowel obstruction from, semaglutide." And I go, "Yeah, but they're not a Miramont patient, are they, Stephanie?" And I go, "That's because we're making them drink water, take some fiber. We go low and slow. We weigh them every month. We're following it." And so we're not seeing those bad outcomes. We're seeing good outcomes, but it's medically supervised. But the state's going to say, "No, we're just going to make it all illegal."
Right.
Well, that's crazy. That's going to create new problems. You're going to make a whole bunch of obese people again, and our Colorado is the thinnest state in the union right now, by the way, and it has been for many years. But we are in some regards the healthiest state in America, and we want to keep that. There's a bill that is looking at changing how smartphone apps can identify whether someone's a minor or not. And this is important for social media because, Facebook, Instagram, they go, "Well, you got to be 18," but yet, every 12-year-old's on
just
it
a lie.
because they just lie about their age. So now they want to have some verification. But the way they want to do it would make it cost prohibitive for me to continue to run my direct health app. So here I am, a small company, 65 employees. We publish an app. You can go to the Google Play Store or the Apple Store, type in direct health for patients. It says, published by Bender Medical Group. Well, that's us. That's Miramont Wellness Centers. And we're publishing it. But if we had to do everything, then we'd have to shut the app down. So really what they're saying is, unless you're Jeff Bezos or Elon Musk, you won't be able to publish smartphone apps. So that's going to stifle innovation. And it's like, well, if a kid gets on a healthcare app, is that a problem? I mean, probably not. If they need healthcare, they need healthcare, and we're probably going to know who their parents are. So it's going to be coordinated. We have to have permission and everything. So we're going to follow that because we have to. So, is that a good bill? I don't know. We spoke to Senator Matt Ball a couple of weeks ago about it, and my chief technology officer, Cody, and my source coder, Gabe, told him, "Hey, this is the scary part. Can you fix that? We're trying to get some carve outs." But it's been a very interactive legislative session. There's one on collections where they want to fine doctors $3,000 for doing medical billing wrong. And one of the reasons that can happen is if the patient has never gotten a bill and suddenly go to collections, it's a $3,000 fine. And so I was talking to one of the lobbyists on this. I said, "You realize that there are people who don't want to pay their medical bills, so they won't give us their address." And so if we don't have their address, the only way we can find them is through a collections company. And we don't send people to collections for $40. But if they owe us $1,000, let's say they needed fracture care 5 visits in a row, and then we found out they didn't have the insurance we thought they did, and they won't get us the new card. Are we supposed to do that for free? And if this gets passed, patients will clobber us with it. They'll go, well, you better not do this, or I'm going to report you and get your $3,000 fine. And again, my bills aren't thousands of dollars like the hospital or specialist. These are hundreds of dollars bills. You might get up to $1,000, but that's pretty uncommon. Is that really fair to small independent primary care offices that are on a nickel margin, And what could the state do better? Because I'm guessing it's large hospital systems sending people to medical bankruptcy that's driving this. Why are you throwing in primary care? Can you carve that out? Can you do something different with it? Do the fines have to be that steep? Is that really going to have the intended outcome you want? Or are we going to have to close clinics in Fort Collins and Parker like we did in Redford Lake, Wellington, and Fairplay because our state legislature made it fiscally unsustainable? And other healthcare systems have not necessarily moved into those areas to take up the healthcare needs of rural and frontier Colorado.
That's it's just crazy that you're trying to do something so good and then you have like just stupid policies and stupid laws come in that just get in the way of you doing what you need to do to help people stay healthy.
Well, and I believe that everyone's trying to do what's right by them. Everyone wants to fix the problem. People have different ideas. Really, what's missing
So you're
is
kinder than I am.
I try. Really, what's missing is the negotiation, reaching an accord. The my way or the highway, and that's happening in our state legislature right now. And let's be honest, it's because we have one party in charge of everything. And I wish the public would look at that and go, you need some counterbalance here. You cannot, if you take a bird and you cut off the right wing and you only have a left wing, that bird ain't going to fly.
Right.
You need to have some counterbalance. And, people they're mad about this at the federal level or whatever, and they're not thinking clear, about what is it going to take to reach an accord. We should really be working on compromise. We should be talking about, okay, where else can we innovate? And put some guardrails in. I'm not saying do free for all. I'm not asking for frontier type policies. We could go completely libertarian. That may not be in the best consumer interest. But there is so much regulation in healthcare right now. People say, well, free market healthcare is failing. It's not a free market, folks. It is not a free market. One of the craziest things I ever had to do in my life was I went to Congress and I testified before the Ways Means Committee. And there was a prominent congressman there named Pete Stark. And Pete Stark wrote what are called the Stark Laws. And many people don't know what these are, but the Stark Laws basically say that physicians can't own and refer to other medical entities. So like if I owned an oxygen supply store in town and I sent everyone who needed oxygen to that place, that would be illegal.
Okay.
Now, Pete Stark meant well because he was concerned that physicians would profiteer. But I'm just going to tell you right now, there's a lot of ways a physician could do that. I could start biopsying freckles, right? And saying, well, here's a mole, we don't do that. There's other ways we keep that in check with boards of medicine and that. All his law did was allow people who haven't taken an oath to, Hippocrates or whatever, didn't take the Hippocratic oath, to get filthy rich. So you now have the CEO of Lincare earning $15 million a year, the CEO of Apria earning $20 million a year. And it makes all this extra paperwork for us to have to get oxygen for people. I finally, because I can, just bought some oxygen concentrators. We put them in-house, and we rent them to people for $50 a week. And we say, if you need oxygen, don't go to the hospital. Just use it. And at some point, if it looks like you're going to need to be on this more than 3 weeks, then we'll go through all the paperwork burden.
Yeah.
But this makes more sense because otherwise I'd have to send people to the emergency room just to get oxygen because I can't get them on with some of the oxygen suppliers, within the moment. And if you need oxygen, you need it now. It can't be a prior authorization process that takes till Monday. That doesn't make sense. But that's what the Stark Law created. So it created more bureaucracy, more overhead costs. It didn't save the government any money. It didn't get rid of bad doctors. It just made it illegal for me to practice what would otherwise be normal in a free market, which is if I have competency in healthcare, I know what my community needs are. We are at higher elevation. We need more oxygen. Maybe if there's not an oxygen company here that's competitive, I should introduce one. No doctor can do that now. Physicians can't own hospitals. That also became law. That was about the time of Obamacare. Again, not a smart decision because typically physician-owned hospitals historically had lower infection rates and had better outcomes and lower costs, but they were concerned about abuse.
But we don't look at the data before we make these decisions.
Right, and some people just hate doctors. I mean, I'm just gonna be honest, and it's like I said, I've had people look at me and go, "Well, you profiteer off people's, disease and pestilence." It's like, well, that's one way to look at it,
Or I
but
cure them.
or I help people in need,
I don't know.
and
Pick a side.
and alleviate pain and suffering. So it's all how you look at it, and and so the reality is that a lot of these regulations, if you go and say, well, did this regulation lower the cost of healthcare? No, healthcare costs continue to rise every year. Most of the innovations that are happening in the legislature, we can call them innovations, interventions might be a better word. Most of the interventions happening with regulatory policy and that in the guise of, consumer safety and that, aren't lowering costs. Every costs just continue to rise. And so at some point, we really do need some kind of deregulation, honestly, to bring healthcare costs down. I don't know that we have the stomach for it though, as a state. Our people are scared. They listen to only one side, and then they hear, okay, no, this is what we've got to do, or people like Bender will be in power, whatever, like whatever that means. But that's the point is how do we get to a sustainable healthcare economy? We have to redo things with insurance. We have to stop using insurance for primary care. We shouldn't be looking at Medicaid for all. That would put me out of business. That would make healthcare costs really unsustainable. Everyone would have a card. They wouldn't have access.
But we wouldn't have access, and we would have long lines and long waits.
And that's been proven. And I lived it, folks, in Fair Play in Wellington.
Look at Canada.
Yeah. And we have tons of people, that are voting with their feet saying, look, I'm willing to pay $85 a month. They're getting good health care. They've been with us for years. And that is a very important program for our community because there's basically 1,200 people that are either underinsured or have no insurance that I'm picking up the slack for, that the for-profit hospital that's supposed to be doing it isn't. And why would you want to take that away from them? That doesn't make sense. And why wouldn't you want to build more of that? Why wouldn't we want laws that sustain that? That's what we need. And so think about that when you go to the ballot box in November. Where is the counterbalance in our state legislature right now? I know it's the midterms. They're saying it's going to swing the other way, but we need to look at it at Colorado. How can we counterbalance things?
Mm-hmm. And across the nation.
That's true.
We do need balance everywhere. I think we need balance everywhere. There was once upon a time, whoever I voted for president, I voted for the opposite in the legislature.
Mm-hmm.
I'm not doing that anymore because things are crazy in Colorado. But
well, and I mean, I have voted for both Democrats and Republicans. I've given money to both sides because historically, I always looked at the person.
That's me.
And
I'm person
you
over
occasionally
party.
get a Fetterman who's like, okay, I'll break with the party line when it needs to be, and I respect that, or a Rand Paul or whatever, they'll kind of go one way and keep their morals, and I think that's part of a good democracy, as opposed to people who just vote the party line. They're just going to boo the other side, that aren't going to work on an accord or try to reach some sort of a negotiation or a middle place. They're just going to break it by not, shut everything down. We're seeing that now with transportation, but they've shut down healthcare too. I mean, there's been times healthcare has been shut down, and we weren't getting paid, and we just kind of lived with it till we got through it. How can we do that? We have to vote differently, and we need to have some counterbalance in the state legislature here in Colorado.
No, I agree. I agree 100%. So if you could get rid of one regulation in Colorado, one regulation at the federal level, what would those regulations be?
Federal level, I get rid of this Stark law in a heartbeat.
That's what I
because I think in the prohibition against physicians, because it's like you either got to trust your doctors or you don't, and I think most physicians want to help people, and they would take their income and their means, and they would invest it back in the programs that they need. Whereas now those decisions are made by hospital CEOs and bean counters. And it's not necessarily what the physician knows their patients actually need. So that power was taken away from us, and I think that's hurt us. At the state level, I would like to see, there was a bill, and I think it's going to get killed. But there was another attempt this year, because there's a bill I wrote during COVID, and then the legislature got shut down. I never made it out of committee. but they took it up again this year, that would allow Medicaid patients to sign up for DPC, because I think it's important. Why would you tell a poor person you're not allowed to have the same health care as everyone else?
Mhm.
You can't go do this you can't do retail. You can't see Bender. That doesn't make sense. You can't go to Miramont. They should be allowed, the state lets them buy tobacco, it lets them buy alcohol, lets them buy, recreational marijuana, but you can't buy health care, because then we're going to, take your doctor's license. That's nuts. That should go away. Um, and we really should look at the Medicaid program redistributing wealth back toward primary care, a lot less towards specialty care. Remember, $7 billion surplus. They've got plenty of money. You
Mhm.
need more in primary care. I can keep the savings going. I already gave you the math. I'm probably saving between 1 and 3 million a year in the local economy because of less reliance on emergency rooms and specialty care and hospitals. Let's create more of that. Let's clone more of that and get our healthcare costs down, because then there's enough left over for every man, woman, and child.
But then you can also get them healthy instead of just keep prescribing them drugs for
Right.
the issues that they have.
Right.
Um, you were talking about earlier compounding pharmaceuticals and how
Mhm.
you're so careful in your office.
Mhm.
So because there's been a lot of talk about closing down compounding pharmacies because of the dangers therein, and I'm a fan of compounding pharmacies when they do it the right way and when there's oversight. So, what kind of oversight would there need to be to keep compounding pharmacies open so that people can get peptides, people can get things that they need without insurance companies taking over and and different things not being available to people anymore?
Compounding pharmacies fill a very, very important need, Dee Dee, because not
That
every
wasn't even my
person,
notes. I just thought of that
yeah,
one off my
not
head.
every person can benefit from a brand name drug. So let me give you an example. Is penicillin a good drug or a bad drug?
Penicillin is a good drug.
Well, of course. I mean, it was one of the first antibiotics ever discovered, Alexander Fleming. And, it cured all kinds of things. It cured strep throat. It cured, cellulitis, your sinus infections, all that. But I will also tell you there are people who took it, had anaphylactic reactions, and died.
Yeah, well, my kids can't take
Right.
penicillin.
So
They're
so
allergic.
for the person who died, I'm just gonna tell you, penicillin was a bad drug,
Yeah.
okay? So not everything works for everybody, and compounding allows for customization of products. If you've got someone with a feeding tube, maybe they can't take the big pill. Sometimes it's better to use it as a salve or an ointment, or to do it as a sublingual drop, but that may not be commercially available. So they compound it.
Mhm.
It's no different than going to a restaurant and you're seeing everything on the menu, you're allergic to everything. You say, "Hey, can the chef make this for me, but take out the gluten?" And they go, "Oh yeah, chef will prepare something special for you, take out the gluten." Or do you want like McDonald's? So they go, "No, we can't do that."
Yeah, right.
We can't change the menu. This is what we have. I mean, so think of compounding as kind of that chef who's allowed in their restaurant to change, digress from the menu to make something that won't hurt the person who's trying to just get nutrition. Now we go to compounding. They're going to create something that won't hurt that person that has a special need. And so, for example, a lot of people have profound fatigue on GLP-1s, or they get really bad nausea. And there's ways you can compound it by adding in some B12, some B6, some L-carnitine, that allows them now to enjoy the same benefits as all the other boys and girls. Well, if we take that away, now how is that going to happen? They can't get their medicine.
Mhm.
So making compounding illegal would just, in my professional opinion, be an extreme disservice to a large swath of our society. The other part of compounding is it is a specialized skill. So not every pharmacist can compound. And in general, large box store pharmacies don't. So Walgreens doesn't compound.
Right.
CVS doesn't compound. You have to go to something locally owned like Good Day is probably the most famous compounding pharmacy here in northern Colorado, to even find a compounding pharmacy, or will order from a national a chain, or I'm sorry, not chain, compounder like Talents IM down in Denver, or Hellendale in Florida, or Anazio, who makes our pellets for the testosterone. So if compounding was made illegal, pellets would go away, compound semaglutide would go away. There are some peptides that have been very instrumental for achieving wellness aspirations for my patients that if they went away, like bioprotective compound 157, which is outstanding for muscle recovery, allows athletes to recover faster.
Mhm.
As far as we can tell, it's not harmful. It occurs naturally in humans. We're just, giving you more of it. Um, but if those went away, if people weren't able to compound them, I mean, we'd survive, but there are some people who would suffer a lot more. And I don't understand the reasoning behind it other than to protect big pharma.
Right.
And pharmacies say, well, our patent can't be breached at all. I mean, this already went to court. The FDA had put the kibosh on compounding pharmacy. Compounding pharmacists sued, got
Mhm.
a court order that said, well, here's your safe harbor. If someone tolerates GLP-1s, I write for Ozempic. I send them across the street. They go to Walgreens, they get brand name, and the insurance hopefully pays for it. If it doesn't, it's, $900. But for people who can't tolerate it, and there are some, it's nice to have alternatives in the marketplace that are legal that allow people to get their care. And, we've made all these exceptions for marijuana. For goodness sake, why wouldn't we do that? Or why would we completely squash rather, compounding? That makes no sense to me.
No, it didn't make sense to me either. I didn't know that that lawsuit had been settled. I knew that it was out there. So I'm glad that it had been settled because I knew that Big Pharma was after the compounding pharmacies. So
Right.
that has been settled?
Right. Yeah. So there are still some states though where it's been a problem.
Okay.
So some states have gone the way that Colorado's looking to go, where they've made it illegal in their state to compound, and those suppliers, they're not participating in the national marketplace now. Um, they by and large are not run by Republicans. So I think we're safe in Texas and in Florida, but there's other states where it's gone the other way.
Well, see, and it's really unfair for consumers.
It is. It is. And governance matters.
Yeah. Governance equal things out, guys. Keep things equal so that we can all stay healthy. Okay. The name of this podcast is More Than One Way to Live a Principled Life. So, what does it look like to practice medicine and with integrity in a system that often makes it difficult to practice medicine with integrity?
Well, that's an outstanding question. So first, there has to be a good mission statement. So because I believe if you have a good mission and you stick to it, that's the best way to keep your guiding principles going. Our mission at Miramont Wellness Centers is to empower your community and yourself to achieve healthcare and wellness aspirations anywhere in life. So breaking that down, empowerment means I'm not doing it for you. You're actually doing part of it for yourself. Your community means we take care of even beyond our own patients. Sometimes we have to involve a spouse or a parent or an adult child to get to where we need to be, or other services, law enforcement, social services. Empower your community and yourself. I want my nurses to be healthy. I had a young gal, we hired her, and I was like, she does not look healthy. A year later, though, she looks healthy. She lost 80 pounds.
Oh, wow.
But
Good for
that
her.
was part of being in our culture, Dee Dee,
Mhm.
right? I mean, it's hard to be at Miramont and smoke. I'm just gonna tell you that right now. I don't know if I have any smokers right now. I think every last one of my MAs who smoke quit,
Wow,
you know?
Dr. Bender, that's
And it's
really
not because we
impressive.
beat them up. It's because they wanted it. They got to the
Mhm.
point where they realized.
Well, if you're the only one in the culture,
Mhm. Yeah, so
that's
so
that's a little peer
peer
pressure.
pressure in a good way.
Yes.
So we wanna achieve health care and wellness because remember, it's not just about being sick. I love people come in and have absolutely nothing wrong with them. They say, "I feel fine," but then I go through stuff and I go, "Well, this is where you need to shore up." You got visceral fat that's too high, or you aren't exercising. I've had people tell me, "I hate the gym." I'm like, "Well, we're gonna come up with something other than gym then so that you can be active and enjoy." So we're gonna do this wellness aspirations. In healthcare, I don't know if you knew this or not, but do you know how we start a doctor note?
Dr. Note?
Yeah, we write the chief complaint. What is the chief complaint? This is the resident rounding what they're attending, at the big
Mhm.
hospital, Mayo Clinic. What is the chief complaint to the patient? This is a 42-year-old female complaining of, menstrual cramps and bleeding of 3 weeks duration. Okay. You have to talk about your chief complaint. Why don't we ask people what their chief aspiration is? Don't tell me just, the stuff that you're complaining about. What is it you really want to do? Well, I want to fly again, but my eyes aren't good. Or I want to be able, to run with my grandkids anymore, but I got a bad hip.
Mm-hmm.
Tell me what your aspiration is. What is your goal? And let's start working toward that goal, that aspiration. So I don't have anything about chief complaint in here.
I
And we want to do
love
it anywhere in life. And anywhere doesn't just mean a place, it means, a station. I want you to have these things, even if you're at the bottom of life, like suicidal, poor, transient. I mean, we have homeless people. I have patients we see that live in their cars. Um, we don't want them to stay there. We have people that are top of their game, but we want them to stay there too. We don't want them to get knocked off. You have to do some maintenance to keep it going. So that's our mission statement, Dee Dee, and that's how we try to look at the integrity.
Mm-hmm.
The other part of it is just having good policies and hiring the best people. I have some very tenured people. Gave Ginger her 17-year pin the other day. Gave Julie her 21-year pin. We have, actually, no, I'm sorry. It's this year, 2026. She got a 23-year pin.
Wow.
Yeah. We have a lot of 10-year pin people, a lot of 8 and 7-year 10 people. My general manager's been with us 12 years. Larissa, who's my team lead, has been with us a decade. A lot of these ladies I hired with their maiden names, they changed their name because they got married, had kids. They've raised their families with us. I've watched their kids grow up, over the years. Kind of curious, if I hire 3 people today, 2 of them won't be here a year from now. That's just the turnover of our society. People move and that. But if they've been with us more than 3 years, they almost never leave.
They
Turnover
stay.
drops down to like nothing. It's like 5%.
Wow.
So I really love that part about the organization.
And you train in different doctors too, right? You bring them in and train them up?
Yeah. So we participate in different programs that'll bring in like medical students or PA students. A lot of them will then go on to graduate and go somewhere else. Many times they have to do residencies and things like that. But we've had a number of people over the years. We've had nurses who've become nurse practitioners that have come back and worked for us. We've had a number of CNAs that have become medical assistants, or even RNs who've come back and worked for Marie Vanacore is a good example. She came to us, medical assistant, and got her RN and is working with us now under her RN license, not as a medical assistant. And that's rewarding to see people achieve their scholastic and academic and vocational dreams.
Mm-hmm. So optimistic or pessimistic about the future of healthcare
Oh,
in our country?
I'm very optimistic.
Good.
So I tell every patient, if I can, I mean, maybe I shouldn't say every patient. I tell most of my patients, probably 90% of them, that I'll do their annual physical. I'd say, I'm renewing your warranty, another 50,000 miles. You're going to live to be 102. And sometimes that throws people off a little bit. They go, well, I don't want to live to be 102. And I'll ask them, have you met someone who's lived to be 102? They're not like you and I. They're confusing that 102-year-old with some 85-year-old who died
Some
on
decrepit.
a ventilator in the ICU.
Yeah.
That's not what I'm talking about. If you live to be 102, you probably have an ideal body weight. You're walking at least a mile a day.
Mm-hmm.
You're eating healthy. And we've had patients who've lived to be 102 in Miramont. The oldest patient ever at Miramont was 107. And that was a long time ago. That was 25 years ago. They were a Good Samaritan village. But we have a number of centenarians, who lived to be 100. And it's an accomplishment. In Larimer County, only about 1 in 7,000 people live to be 100. So if you do that,
Wow.
it's a big deal. But what I look at is, what is this person's aspiration? Are they planning? If you start thinking now, well, I'm not going to live to be 100, I'm only going to live to be 80. You might only make 60 because you've already gotten that pessimistic mode of I'm not going to make it, right?
Yeah.
I mean, that's if you want to aim for here and you end up here, that's great. But if you aim here and you end up here, that's not great at all.
Well, that only gives me another year, so I'm not aiming
think
there.
people make that mistake all the time. And so the best pathway to longevity is vitality now.
Mm-hmm.
You should be at your ideal body weight now. You should. And so I'm trying to live this in my life. I mean, I work out 8 times a week, which sounds like a lot, but I go Choose Fitness every morning and I do my 7.5-minute run. I've got an artificial hip. I don't let that hold me back. I fully rehabilitate it. I go Taekwondo 2 nights a week. Not because, I want to fight, but it's really good for balance and for flexibility and for endurance. They work as hard. And you have to do it their way. And so that forces me to have to discipline myself. And I'm a lifelong learner. I think people, I picked up flying again. I hadn't flown in 29 years, started going back to that. I got my MBA when I was in my 40s, after I had my
That's
MD.
when I got my master's degree in my
Yeah,
40s.
but, I'm trying to learn to speak Spanish, so I've hired some really wonderful Spanish ladies that help me to learn, and I practice with my patients, because I'm gonna go to Madrid, Spain, and see the total eclipse of the sun. But, I've got my 9 grandkids, I wanna be around for them.
Mhm.
So I set the framework of what does it take to live to be 102 with my patients? And they should aim for that, and if they, "Well, why don't you think you?" "Well, my family all got dementia." Okay, what your genes are your tendencies, they're not your destiny.
Right.
So here's my example of that, right? I'm very pale. I sunburn easily. So, and there are people who aren't pale that don't sunburn easily, right? So I don't have that gene. That doesn't mean I ever have to be sunburned again. I don't ever have to be sunburned. I can wear a wide brim hat. I can do my SPF 30. I can, be responsible with my UV protective clothing. I don't ever have to have a sunburn again. So it's the same with almost any gene you have. You may have the breast cancer gene, doesn't mean you're going to die of breast cancer. There are ways to keep from dying of breast cancer if you have the breast cancer gene. Get your mammograms. So if people start living in an assumptive posture of, hey, I'm going to live to be 102, they're probably going to make it to at least 90, right? Whereas if you start thinking, well, I'm not going to live, I don't even know I want to be 85. Dude, you're going to be gone at 65. I mean, that is not the way to look at it. You got to have that mindset to win.
Mhm.
You got to have that winner's attitude. And if you're able-bodied and if your faculties are there, why not live to be 102? And the 102-year-old people I knew were amazing. In fact, I did some interviews with them before they died because I'm like, I have to start documenting this so people can see what a 102-year-old person actually looks like because they're incredible people. And, one of the gals I went and interviewed, she's 102. She still walked a mile every day.
Well, that's why she's 102.
Yeah, yeah,
That's why she
yeah. And she walked a mile every day. And there's people who just sit in their chair and they don't walk and,
and
use
they're
it or
not
lose
gonna
it.
live to
And you
102.
don't, right?
No.
So you have to have that mindset. And I think that, that's really what I hope that when I'm gone, they look back, they go, this doctor had a lot of people that lived to be 102. What the heck was going on?
What did he do right?
Exactly.
My father's side of the family, I always joke that we kill all of our men because they live forever.
Mhm.
They live until their 90s and hundreds and early hundreds, but they're always doing. They're
Right.
gardening and they're learning to paint and they're playing bridge and members of the country club and they're just always doing. So in my brain, it has never occurred to me that I wouldn't live into my 90s and early hundreds. I
Mhm.
remember going to visit my great aunt Alice. Was she a great or great great? I think at the time she was a great. Anyway, we went to visit her. We're at her house in Arkansas and it was really hot. We're on her front porch and the TV is blaring. And we're pounding on the door. The screen door is open. We can hear the television and she's not coming to the door. She's like 100 years old. And we just see, look closer through the screen door. We see these little legs like this on the floor. She is lying on the floor with her head in her hands and her little legs just doing this on the floor. She's 100 years old. How many 100 year old women do you know that can lay on the floor
Not
on their
not
bellies with their
many.
little
Right, right.
yeah, my great aunt Alice. So those are the genes in my family. So I'm feeling pretty good.
Well, and it is interesting you mention this because there's a book, called The Blue Zones, written by Dan Buettner.
Of around the
Yeah,
country,
and
around the
he looked
world.
around the world and he
Mhm.
found the places where people live to be the longest, and so it's like the island of
It's not
Sardinia
Arkansas.
and the island of, Icaria and
Right.
the,
There was a place in Italy.
yeah, peninsula in Costa Rica, the Nicoya Peninsula,
Mhm. And
and
it was the Latter-day Saints right here
they
in the
they
United
did,
States?
and then they also looked at, Okinawa, and Okinawa probably is really, one of the better blue zones as far as number of people living, and what's curious about Okinawa, if you remember during World War II, Dee Dee, that place got obliterated. I mean, that's where
Mhm.
a lot of Marines, a lot of Japanese, soldiers lost their lives fighting, and the people who are 102 now were alive back then. They lived through that, so you can live through, like, a terrible war and still live to be 102. But when they were studying them, they found certain patterns. And one of the things is that in the Japanese culture, they sleep on the floor.
Mhm.
And so these 100-year-old ladies, every day they had to get down on the floor and then they had to get back up. Well, in the States, we sleep in a bed and we don't get on the floor, and I get on the floor every day. I mean, I do for my push-ups and stuff that Taekwondo makes me do. But there are people get to be 60, 70, 80, they haven't been on the floor in a decade.
Mhm.
And if they fall at home alone and they don't break their hip, they might still lie there for a day and a half because they don't have the core
Yeah.
strength to get up. And yet if you sleep on the floor every day, you do.
Mhm.
And so it
And if you
sounds
sit on the floor,
trivial.
a lot of those
Mhm.
cultures too, they
Right.
sit or they squat.
Sit low.
Mhm. And they walk up and down hills.
That's the other thing is one of the first thing we do with mom and dad, we go, "Oh, we gotta put your ranch home, no more stairs." But all the places we just mentioned, these blue zones, Sardinia and the Nagoya Peninsula and Okinawa, a lot of them are rising out of the ocean very steeply,
Mhm.
and so it's all vertical living. They don't have nursing homes. Most of the time, it's multi-generational
Mhm.
living, 3 or 4 generations, same house. Many of them have multiple kids. If you're the child that takes care of mom and dad, statistically, you live longer than your siblings. So that's another thing. Don't feel bad if you're the squeeze generation. You're probably gonna live longer, and maybe that's artifact because the healthier child is the one who ends up taking on that burden. But they're more likely to garden and to eat their own produce, which makes them
Mhm.
healthier because they're not eating as many processed foods. They limit alcohol, maybe, a little bit of sake or a little bit of red wine, tend to be the healthier ones. They have a deep spiritual connection, you
Mhm.
know, and a deep spiritual connection to their community. They have an identity in their community. They don't retire. In fact, in Okinawa, there wasn't a word for retirement until the modern age. You fished till you were 100. That was
Mhm.
it. You never stopped. And in the US of A, retirement age is one of the most dangerous ages in life. Like over and over again, especially if you're like a fireman or a policeman or a teacher, where a lot of your self worth and recognition, identity came from what
Mhm.
you did and your interaction with the community, and suddenly that's all gone. And if you're not setting your alarm clock or waking up or having a routine, it can be really hard on people. They stress eat, they gain a bunch of weight, and they die,
Mhm.
silent heart attack or whatever. So I tell people, I wouldn't worry about retirement. I don't know that you need to retire. If you enjoy what you love,
Mhm. Or if you do, you still need to have a third act. It's like,
right,
what's the next thing? It
right.
can't just be golf. There needs to be something
Contribute back to the community.
where you have
Yeah,
that validation, where you have something that you're looking forward to, that you do need to set that alarm clock and you need to have that purpose, that sense of purpose and
and purpose
fulfillment.
is very important. A lot of people have no sense of purpose in
Mhm.
their 90s, and they get to the point of, okay, well, I graduated high school, I graduated college, I got married, I had kids, I had grandkids, I got my job, I retired from my job. I toured the world. Now there's nothing left. The last thing to do is die, and that becomes the only thing they can focus on,
Yeah.
as opposed to, you know, being so involved in other people's lives or service that they have that sense of identity. They know what they're on the planet to do.
Right. And finding it.
Mhm.
If you don't want to work, you don't have to work, but you need to do something. There
Exactly.
needs to be an involvement in something, which is why we're doing this now.
Exactly.
Sense of purpose.
I know. Next time we should do this on an exercise bike or something. We've been sitting a long
I
time, and
know.
sitting is the new smoking.
It is. Well, I bought upstairs, I have this pad that is 3/4 of an inch because that is supposed to be the ideal sitting pad. And I put it on the floor and I sit for at least 30 minutes to an hour
I love it.
on my
Mm.
pad
Little
every day
golf
so that
clap
I
for
can
you
get
there,
up and
dude.
down and
That's
up and
good.
down from the floor.
Mhm.
Remember when I made you do that in your office?
Yes, yes. Yeah, well, that's a good skill, and it
Yeah.
requires some balance, it requires
Mhm.
coordination and a lot of good core strength, and core strength gets underrated. It actually improves continence, like people who leak urine, like
Yeah.
just increasing your core can help with that, so it's
Yeah, I
it's
had a
it's
trainer
good
who
for more
used
than
to
just
make me do
sit-ups.
duck walks after I had my baby. Duck
Mhm.
walks? I had to
Yeah,
do
yeah,
duck
yeah.
walks to bring that
That no,
back.
core a healthy core is important. No one wants to leak urine.
All right, well, before we go, because I know we have been sitting for a long time, we need to and these chairs are pretty, but boy, they're
The
not the most comfortable.
mine's actually pretty
I know
nice.
that's the best one.
Yeah, you
That's
be
why I
careful,
usually
I'll fall
sit there.
asleep here.
Okay, rapid fire questions. You ready?
Yep.
What is the biggest myth about healthcare?
The biggest myth about healthcare, I don't know, there's a lot of myths. I'm trying to
You can name more
say
than one.
something that is good, but, the biggest myth is that if I'm on an expensive drug, then there's nothing I can do about it. I just have to spend a lot of money. The reality is that there are oftentimes many other treatments that are way less costly that if you just gave them a chance, it would work. And I take a lot of people off of very expensive medicines and get them on cheap meds, but it's hard to get people to believe it. They're convinced that they need that billion-dollar drug when really they could use something that's very inexpensive and probably get the same result.
Like what? Give me one.
Well, like with antibiotics sometimes, or there's very expensive medicines for acne, like called Accutane, and there's some
Mhm.
generics out there that are like a third of the price. We had a patient who needed a drug called fluconazole, and no pharmacy would sell it to them for under like $600 because there's a very inexpensive version that's 150 milligram, but if you have to take it daily for 30 days, they like suddenly charge an incredible amount, an insane amount. And I was able to source it through one of our supply chains for, I don't know, like $20. So there's oftentimes solutions that will work that are a lot less costly.
I'll take the less costly for $5, please. One thing patients should stop doing now.
They should stop. Well, I like to frame it more in at things they should start
Okay,
doing.
what should they start doing?
They should start eating more fresh produce. So if I say eat less junk food, then they don't know what to eat. But if I say eat more fresh produce, they'll eat less junk food anyway. So that works better for me.
Okay.
So like broccoli, bell peppers, cucumbers, celery, spinach, sweet potatoes, blueberries, blackberries, strawberries. Farmers market's gonna be opening here soon.
And it's planting season, so you can
Mhm.
always start growing stuff.
Yeah, go to the, grocery store, pick 3 vegetables you've never eaten before, take them home, figure out how to cook them. Like, I did that with I think it was called jicama, I'd never had jicama
Oh, it's
before.
good.
Yeah, well, I learned that because 'cause I'd
Yes.
never had it, it wasn't something we were raised with, but,
Yep.
uh, cook an artichoke, if you've never had artichoke, go home,
Celery
cook
root
it.
instead of potatoes?
Mhm. Yeah. Yeah, white potatoes and corn, I don't usually recommend those. I'm not even sure corn's food. I think corn is a grass. And it
It's like something
became
I try to
popular.
eat
It's a
only a couple
filler.
times a year.
Yeah.
It's so good, but I try to limit it to, like, a barbecue
Yeah, I
once
mean, if
once
you
in a
pop it,
while.
you see what's inside. It's basically styrofoam. It's
Yeah.
there are certain foods that um, if you eat them by themselves, you could live, a full life. So, like, if you were stuck on a desert island and all you had was salmon, you could, like, survive. You could just live off of
Mhm.
salmon, but you couldn't off of corn. If you just had only corn to eat, eventually you would become deficient of certain amino
Right.
acids and you would die.
But purple potatoes are really good.
Those are really good, yeah. So I don't wanna say stop eating junk food, I just wanna say start eating healthy food, and that'll push out the junk food.
Push out the junk food. Okay, what, is one thing doctors wish they could say out loud?
Oh my gosh.
Spoiler alert, he's gonna say it.
Yeah,
He's gonna
I there are some people that are really embarrassed about their bodies, and I wish I could tell them they don't have to be embarrassed about their bodies, but I have to be careful about how that's phrased, so, because there's gotta be a boundary, between the
Mhm.
patient and the doctor. But there are people who they really feel ugly or they feel embarrassed about things, like they won't wanna talk about incontinence, we brought that up earlier, and there are so many outstanding treatments for it now, like, I haven't sent people for surgery for incontinence in several years now because we have a number of treatments at Miramont that work, like M-Cell Chair, Morpheus, but how do I bring that up without embarrassing the patient? Because a lot of times it's just too sensitive, it's too intimate, and they don't
Mhm.
wanna talk about it. I'm comfortable talking about it because I do it every day, but they're not, and I have to respect that, and so, just helping them to get to the point where they're not embarrassed about it or ashamed about their body, they can talk about it matter of fact, so they can fix it, and then it's now they're into wellness, right? That was their past.
Then they don't have to worry about it anymore.
Right, but getting people to where they're comfortable about it and not embarrassed.
Okay, so ladies, if you have a problem sneezing, you can talk about it.
Yes, yes, and you should, and the sooner the better because it only gets bad news doesn't get better with time.
Okay, we might have to have a
It gets
conversation
worse. Yep.
because I sneeze.
Mhm.
Um,
Coughing or laughing too, yeah.
baby number 2.
Right.
This is not something I'm embarrassed to talk about, obviously.
Right.
I've talked about it with everybody, so I didn't know that there were things you could do about it. So this is a really good
There are
conversation for
more
me.
adult diapers sold in the US
Not
than
know
baby
this.
diapers.
Well, I don't wear adult diapers, but
I know, but
I
I'm
do
just
wear
making
some
the point
special
that
little pads
that most Americans would
called
think
poise.
most Americans wouldn't realize, that there's more adult pads sold than baby diapers.
No, I didn't know that there were
Yeah.
things you could do.
Yeah. Yeah.
So glad you came today, just for
There are
that one little
no,
tidbit.
there's a lot of things that can be helpful. Yeah.
Glad
Yep.
we're here. What does it look like to live a principled life? Oh, we already talked about that.
Mhm.
We did that question already. I
Yep.
asked that one earlier. So, any closing thoughts, remarks, words of wisdom you want to share before we wrap? This was great, by the way. You
start
are a fabulous,
Thank you. I
fabulous person
appreciate
to
it.
sit and have a conversation with. This
Well,
is
I had a
great.
lot of fun. This really worked out well for both of us. Start researching peptides. Peptides are becoming really big.
Mhm.
They're a disruptor. I'll be interested to see what RFK does with them, because there's some push from the FDA to maybe start regulating them in a way that'll
Mhm.
make them hard to access. For the most part, most of them are very safe. There's probably a few that need to be regulated. But in addition to the GLP-1s, which are glucagon-like peptides, which have created this, weight loss revolution here in the U.S., there are a number of performance-enhancing peptides that help people with exercise, help with mental focus, help at the mitochondrial level
And
to make our
healing, right?
cells do better and to heal faster.
Yeah.
And we should all, as Americans, be looking at that and figure out, well, what peptides do I need, and talking to our doctor, and hopefully they won't overregulate them the way that we talked about has happened so much in this industry that makes it almost impossible then for people to get well.
All right. All about wellness and health.
It is,
And
yes.
doing it directly and
Yes.
avoiding hospitals and long lines and waits and bureaucracy, because
Yes.
direct primary care, guys, is really the way to go.
Advocate for yourself. Don't stay a patient forever. Become a well person and set your goals for 102.
102.
Yep.
All right. Thanks so much. Bye, everybody.
Bye. Thank you.
Bye. That was so fun.
Yes,
You were
thank
the
you, Dee.
best.
That was awesome. I appreciate you saying so. That was
Did
fun.
not know about the incontinence.